Forward, Mr. Brown.
Evaristo, kalispera. Right. It's an absolute honour to be here. When I was asked a couple of weeks ago would I come and do this talk, I jumped at the chance. I love Greece, the opportunity to get away from the sleet in London, come and get some warmth in Athens. It was an obvious thing to say yes. I said, yes, please, I'm coming. A couple of days ago, I looked at the title of the lecture that I'd been given, and my heart began to sink, and I thought, well, what am I going to be able to say about this? Do we really need to individualise treatment? And then I looked at the rest of the programme for today, and my heart sank even lower, because I realised that everything there is to be said has already been said. So, I'm going to start with 3 apologies. The first apology is it's going to be in English. Je parle français, ich spreche Deutsch, hablo español, parlo italiano, falo português, but I cannot yet speak Greek, so forgive me, it's going to be in English. The second apology is that it's probably going to be repeating everything you've said, but it doesn't matter. It's repetition to reinforce things. And the third is that I'm going to make you work at this. I was under the impression that I'd got voting keypads. Here we are, the home of democracy. You're all quite good at voting. I think you voted just a few days ago. So I'm going to get you to vote with your hands today because you haven't got the keypads. It's going to be like Australia. It's illegal in Australia not to vote. So you've all got to vote, but maybe moving your arms around will keep you a little bit more awake because you've been very good and patient, and I know we're coming to the end of the session. The obvious disclaimers. Right, so first vote. When I was confronted with this, what do you consider to be individualised treatment? Is it A, choosing a treatment regimen that will offer the individual patient the greatest chance of achieving an SVR? Is it B, choosing a treatment that's most acceptable to that individual patient in terms of duration or side effects? Or C, is it actually about coming up with local or national treatment guidelines that will derive the best outcome in your patient population with the available resources? So who's going to vote for A? Few of you. Oh yeah, more. It's going. Okay. See, everyone wants someone to vote first. No one wants to be the first. B or C? That's good. I'm glad I've got a few C's on board. Now, let me just, the same answers, but I'm rephrasing the question. As a practicing clinician, which of those do you think should be your priority? Is it about A, getting the maximum SVR in each patient? Is it B, about minimum side effects? Or C, do you have a duty as a physician to see that you can do the best with what you've got available? So again, for A, for B, or for C? Yeah, good. If I'd asked that question in an American conference, every single hand would have gone up for A. The Americans are petrified of being sued for not giving their patients the best treatment. And hang the cost, it doesn't matter. But I think that we both come from societies with a more socialised approach to medicine, where we actually have to think about our responsibilities when it comes to individualising treatment. Now here we are. Yesterday, fantastic tour of the new museum of the Acropolis. Why is history important? History is important because we learn not to make mistakes in the future by looking at what we've done in the past. So indulge me for a moment whilst we run through where we've come from with the directly acting antivirals. So this is where the clever boys all discovered how hepatitis C works. And of course, the first drug that we had was the protease inhibitor. It seems like only yesterday, it was in fact about 3 years ago, when boceprevir and telaprevir were launched, and I stood up at similar meetings to this 3 years ago saying, everything is over now, this is fantastic, we have the answers, it's plain sailing from here. And the reason was clear, that we'd upped our SVR rates from 35–40% in our genotype 1 patients to 75%. We thought it was a miracle. How can it get better? Of course, what was apparently heaven quickly turned into hell when we started actually using these drugs and realizing how difficult it was, how complicated, the side effects, the drug dosing schedules that we had to follow. The good thing was that suddenly it made us hepatologists look very clever doctors. We were dealing with these difficult drugs all the patients had to come to us because we were the only ones that could manage the dermatological problems, the dosing, the other issues related. But I think we were all quite happy to say goodbye to boceprevir and telaprevir. Along came the second wave of DAA. So now we had not only the target of the protease inhibitors, we had the polymerase inhibitors, and we had the NS5A inhibitors. And from what we'd learned with HIV, from tuberculosis, that by putting together combinations of these drugs that affected different points in the replication cycle, we could come up with an answer. Now, of course, all of those drugs initially were launched, one from each class: cimeprevir, the protease inhibitor, declatazvir, the NS5A inhibitor, and sofosbuvir, the polymerase inhibitor, the nucleotide, from 3 different companies, were all launched within a year of each other to be used with PEG-RIBA. However, doctors are like children in many ways. And if you give children toys, they want to play with their toys. We didn't like the idea of having to use interferon and ribavirin anymore, and so the rich children started putting together the different toys in what I call the mix and match era. Now again, the rich children live in the USA, they live in France, and they live in Germany, and sometimes rich children live in universities. But for most of us poor children, this really wasn't an option. So the first experiments were putting together 2 or 3 of those drugs, particularly Simsof, a new word in the German dictionary, or sofosbuvir declatazvir, or sofosbuvir ribavirin in genotype 3, as we've heard earlier, to see what could be achieved. Of course, as already alluded to, no pharmaceutical company was happy to join together. We all thought it would be the brave new world of HIV, where BMS and Gilead happily were going to get into bed together and bring forward these combination drugs. It wasn't going to happen. So it was up to the clinicians to put together these combinations. And this again is the target data. We've already seen this several times today. But you can see here in genotype 1, when given the choice, the run of the sweetie shop, that many physicians put together cimeprevir and sofosbuvir with or without ribavirin. For the genotype 2 and 3 patients, sofosbuvir ribavirin was the obvious choice. What we can see there as a proof of concept, all oral therapies by combining different drug classes works extremely well. SVR rates there in genotype 1 patients in the 80s. Of course, as somebody has already suggested, if we choose to dine à la carte, it's not a cheap option. I'm sure you're aware of the prices, but just to remind you, a 12-week course of cimeprevir plus sofosbuvir costs around about 80,000 to 100,000 euros. If you want to use that for 24 weeks, as a lot of these physicians were using it for, you're nudging up then towards 200,000 euros per patient. Just think how many people you can treat with PEG-RIBA for that price. So what's happening in the future? Well, if Professor Manns had €1 for every time this slide had been shown, he could retire. But we know there is a whole lot of drugs coming forward in the pipeline. And again, Professor Hadzianis earlier on talked about how we could combine these. These are the protease inhibitors. Boceprevir, telaprevir, goodbye, good riddance. We now have cimeprevir, paritaprevir. But you can see here all these other drugs coming through. The early protease inhibitors were genotype 1 only and had a very low barrier to resistance. The second generation, the second wave protease inhibitors, still a low barrier to resistance, but beginning to become, the new word is oligogenotypic. They work in several genotypes, particularly 2 and 4. Still that missing link for genotype 3. But we're looking forward to the protease inhibitors of the future, grazioprovir and the Achilleon protease inhibitor, where they are truly pangenotypic and a high barrier to resistance, that perfect combination that we want in an antiviral. The polymerase inhibitors can be divided into the nucleotide and the non-nucleotide analogues. Sofosbuvir at the moment is the only nucleotide analogue, and we know the experience from sofosbuvir tells us not only is this pangenotypic, but this has an incredibly high barrier to resistance. I often think that someone at Gilead has sold their soul to the devil in that they now have an antiviral for both B and C that appears to have little or no resistance. But that is not the only one in the pipeline. Merck and Achillion both have nucleotide analog polymerase inhibitors that offer the same sorts of resistance profile and pangenotypicity as sofosbuvir. And of course, in the non-nukes, we have dasabuvir now, which is the AbbVie polymerase inhibitor. But again, there are other drugs coming through, baclabuvir from BMS, and other drugs coming through, which will offer us non-nuke combinations. The NS5A inhibitors, we've got the first generation, declatazvir, ladipazvir, ombitazvir. Again, oligogenotypic, really only working in genotypes 1 and 4, and a relatively low barrier to resistance. But coming through in the near future, we have these pangenotypic, medium barrier to resistant second generation NS5As that offer us additional advantages. So, just like the HIV physicians, let's get cooking. The shop is open. All these different beautiful drugs are available to us. Let's make a moussaka. Jean-Michel Pavlotsky, many of you will know, is the original French chef when it comes to Hep C combinations, and he wrote the recipe book. And these are the combinations that he has always suggested. On the first, the option 1, if you've got one of these nucleotide polymerases, hang on, can't get the mouse. There we go. The nucleotide polymerases, is this going to work? No, don't worry. The high barrier drug, if you've got one high barrier drug, pangenotypic, you can pretty much add whatever you want to it. That's the situation we're in at the moment. Sofosbuvir is the backbone. You can pretty much pluck anything else you want to put with it. Option 2 is if you haven't got that high barrier NS5A high barrier nucleotide polymerase, you probably need to start to combine 3 different drugs together: the protease, the polymerase, and the NS5A. And of course, that's the recipe that AbbVie are following with paritaprevir, ombitazvir, dasabuvir. We can look forward to option 3, where if you combine one of the new second-generation NS5A inhibitors with a second-generation protease inhibitor, then you can get away with 2 drugs, and that's what Merck is going for. That's the elbasvir-grazoprevir combination that's not going to have a nuke polymerase in it. So there we go. There's your recipe book. Go away, be creative, do whatever you like. No. Because, as I said before, the idea of each of the pharmaceutical companies is that they're going to come up with their own options. We've seen sofosbuvir, ladipazvir, fixed-dose combination from Gilead. We've got paritaprevir, ombitazvir as a fixed-dose combination from AbbVie, to which we would add the dasabuvir. So here they are. This is what I call the pret-à-porter range, because you're buying it off the peg. So you've got 1 or 2 options now of which you wish to buy. The reality is that each of the pharmaceutical companies is holding out for the royal flush. In other words, the same suits, but the 3 cards that will be there. Because in the very near future, within the next 2 years, we will have Merck's combination. We've got Gilead and AbbVie's already. We'll have Merck's. Gilead, of course, ladipazvir has got a very short half-life in the sun. It will probably stay on the shelves less time than telaprevir, because GS5816 is a pangenotypic drug that is going to come forward and take its place very quickly. Declatazvir plus asanaprevir from BMS, not a fantastic combination. Asanaprevir is not a terribly effective NS5A, but adding in baclabuvir, there's your royal flush, 1 from each drug, so we can expect BMS to be coming forward with a combination very soon. And Janssen, who've served us well with telaprevir and simeprevir, are also coming forward with somatosvir and 055, so they'll have their royal flush. So pretty soon, the only choice we will have is which combination do we buy. We can't buy the individual ingredients. I might want eggs, but if I go to the supermarket, there's no point in me buying a cake because I won't be able to get the eggs out of it. I might choose to put together paracetprovir and ladipasvir because I think theoretically that's a good option, but I can't get the ladipasvir out of the fixed-dose Harvoni, so it's irrelevant. Because in fact, what we're moving forward to is the ready meal era. So we might know a fantastic recipe for making a moussaka, but unfortunately we can't buy the ingredients, so we're going to have to buy the ready meal and pop it in the microwave. It's fine, it's nutritionally good, it's going to fill us up, it will cure the hepatitis C. Well, moussaka doesn't, but the drug combination will. But that's the choice that we will have in the future. And I always say, actually, yeah, I've got a number of suits. I've got a lot of suits that I buy from the high streets. I've got one suit that I went to a nice tailor but bought it off the peg. And in a moment of madness, I once had a suit made to measure. Now, when I wear the made to measure suit, I feel a lot better. But in fact, it's very hard to tell which is which. What one am I wearing today? Marks and Spencer's £100, but don't worry, off the peg. You know, you probably think it looks shabby, but never mind. The reality is that as long as the suit keeps me warm and stops me appearing on stage naked, it does the job. And it may well be that we're going to have to accept the fact that most of these do the job. In fact, we're probably going to go one step further. We probably won't even have the choice of whether we want the ready meal spaghetti bolognese or the ready meal moussaka, because in my country, what I suspect, my Department of Health will go out to the 5 companies and say, this year we're going to treat 10,000 patients. How much are you going to charge us for your particular ready meal? And I think we will be told, this year, Merck has got the contract, everybody is having the Merck combination. So I think choice will be taken away. So the point of all this is that we can no longer individualise, or it's unlikely that we're going to be able to individualise patient treatment on the basis of which drugs we use. So how can we individualise treatment? Well, maybe we should individualise treatment by those pre-treatment patient characteristics. We're very used from the interferon days to looking at that list on the left and say they do badly, and looking at that list on the right and saying they do very well, and we can therefore choose which drugs we're going to use for which groups. The reality is that even in the interferon-containing regimens, what we used to think of as poor predictors are actually make very little difference. And in fact, when we come to the all-oral options, it really does become an irrelevance. This is the neutrino study. This is looking at a patient with all 5 bad characteristics. So this was an advanced fibrosis, black patient, non-CC, high viral load. And you can see that even in an interferon-containing regimen, 71%. It may be that the accumulation of all of those factors drags it down a little bit. But I suspect that with the all-oral regimens, most of these things become an irrelevance. So should we treat on fibrosis stage? Again, we know that in the interferon days, advanced fibrosis did less well. We've heard from speakers today. This is the cimetravir data. Even with cirrhosis, cimetravir patients get a 71% SVR rate. This is the interferon-containing sofosbuvir, 80%. But when we move to the all-oral combinations, cirrhosis becomes irrelevant. 92% versus 96% with the AbbVie combination. This was Professor Boulier's data he presented earlier on. This was a poster at Arseld. Again, you can see there that when they used the ladipasvir sofosbuvir for just 12 weeks, 95%. The question we have to ask ourselves, these are not statistically different, but even if they were, if we had 200 doses of a drug, we could treat 100 people for 24 weeks, or we could treat 200 people for 12 weeks. On the one hand, we're going to get 96 cures. On the other hand, we'll get 182 cures. Now, if you're one of those 4 patients that misses out because you don't get the 24 weeks, in America you'd sue your doctor. But are we prepared to sacrifice those 4 patients for the benefit of the other 80 patients, additional 90 patients who are going to get a cure? That's the question we have to start asking ourselves. Just to say there, of course, that evaluation of fibrosis is still important because we need to monitor those patients for HCC. But essentially, we probably don't even need to know the fibrosis scale. We're about to set up studies in Africa where we are going out, we're doing point-of-care antigen testing, we're giving treatment for 12 weeks all oral, no monitoring, no testing, no FibroScan, no biopsy, no nothing. We come back 12 weeks post-treatment and do one more antigen test. That is the way we're going to deliver care in developing countries because we're not going to be basing it on fibrosis. What about viral kinetics? We heard earlier on about early virological response, rapid virological response. You remember these charts? Probably still got them plastered on your office wall. The nurses are always coming to ask me, so if they were under 25 at week 12 and detectable at week 24, is it 36 weeks of PEG-RIBA or is it 48? They're gone. Put them in the bin. Even cimeprevir has no response-guided therapy. There's one single futility rule, but apart from that, response-guided therapy has gone. So we are no longer beginning doing response-guided therapy. With the new drugs, the virus suppresses very, very early, very, very quickly. What this means is we haven't got to do those PCR tests. That's going to cut down on costs because we're not going to get there. What was interesting, the last speaker showed that in those patients with advanced fibrosis, often the suppression is slower. In the UK, we've got 750 patients with Child-Pugh B and Child-Pugh C cirrhosis on all oral combinations, either sofosbuvir ladipasvir or sofosbuvir declatosvir. The government only agreed to pay for 12 weeks of treatment. A lot of physicians got very upset by patients who at week 8 still had detectable virus, saying we must continue their treatment, we must put them out to 24 weeks. The government said no. For once, the government was probably right. So even those patients who suppress late, it doesn't seem to affect the SVR rate. In the clinical trials, we had patients who still had target-detected virus at end of treatment, who subsequently had an SVR. So response-guided therapy, viral kinetics, out the window. What about extending treatment? Again, we've seen this. 12 weeks versus 24 weeks makes little or no difference. That was the ION-1 study. This is the ION-3 that actually showed that 8 weeks is probably enough. This is the next slide. There we go. Is the ION-2. Treatment experienced, possibly a slight decline. This is the AbbVie data, again, 12 weeks in some null responders, probably a little bit less. In the 1B, that's fine, 12 weeks is enough, and that's what leads us to those data, the licenses to say that in some patients we need 24 weeks. But I bring you back to my earlier explanation that we need to think about how we best utilize, and would it not be better to give everybody 12 weeks and then those small number that fail, put them onto a more expensive regimen to just pick up the extra patients at the end. What about ribavirin, good or evil? You've had a lecture on this morning. My next, I think the batteries are going. Okay, next voting. Do you think that ribavirin is the work of the devil and belongs in the bin? 2, I will use it if it improves my SVR rate. If it will improve the SVR rate, then the price is worth paying. Number 3, if it means I can save money, then I can manage the side effects. Or do you believe that both 2 and 3? So number 1, again in America, that all their hands would be up. Number 2, number 3, number 4. Excellent. Number 4 it is. So, again, we've seen the data. I'm not going to dwell on this. With or without ribavirin in genotype 1 naive patients doesn't make a lot of difference. This is the AbbVie data. Again, in 1B patients, no difference whatsoever. Possibly some difference in the 1A. This again is the Marc Boulier paper, 12 weeks soft riba. This was in patients with cirrhosis versus 24 weeks with ribavirin, little or no difference. In the UK cohort, it was left to physician discretion. I put every one of my 55 patients on ribavirin. Every one of them got through with their ribavirin. We're having SVR rates around 95% in Child's Pugh B and C patients. Remember that the hemolysis caused by the ribavirin can be corrected if your bone marrow is still producing red cells. It's the interferon that paralyzes the bone marrow. So we see about 10% of patients with ribavirin monotherapy that have severe anemia. Right, a little bit of history. I was fascinated up on the Acropolis yesterday to see the Theatre of Dionysus, is that right? And the guide was explaining to me how this was situated next to the hospital and that there was this very close link between drama and medicine. And most of you will know I'm a doctor, but what most of you won't know is that I'm actually also an actor. And I have a great interest in the combination of theatre and medicine. So my next question to you is, does anybody know who that is? And it's not me on a good day. No, not Dostoevsky. That's George Bernard Shaw. Okay, George Bernard Shaw was an Irishman who lived in Britain, famous playwright. He wrote, amongst other things, Pygmalion, which of course is based on a Greek tragedy, but was turned into the musical My Fair Lady. But he also wrote this book here, this play called The Doctor's Dilemma, which I actually appeared in a few years ago. And it's, for those of you who are interested in the theatre, read The Doctor's Dilemma. It's a fascinating story. It was written in 1906, and it tells the story of a young doctor who has discovered a cure for a germ. Remember, this is before we understood about bacteria and viruses. And it's actually clearly talking about tuberculosis. And he discovers the cure for tuberculosis. The problem is it's very expensive and very difficult to make. And he only has 10 doses. And he has 50 patients in his clinic. And he has to decide which patients get the drug and which ones don't. And he's already given out 9 doses of the drug, and he only has 1 dose left. And he sees 2 people, one of whom is a colleague of his, an old and very respected doctor who's worked for many years in the field, and that's why he's got tuberculosis, and he's asking for the drug. The other is a young artist, a fantastic artist, great talent, but a horrible person, a womanizer, an alcoholic, but he's got great talents. And it's made more difficult by the fact that the artist himself doesn't come, the artist's wife comes, who's a beautiful woman. And the doctor falls in love with the artist's wife. So the dilemma he has is, does he give the drug to the old doctor, who's going to die soon anyway, but has all that wisdom? Or does he give it to the artist? But if he doesn't give it to the artist, he could marry the widow. So it's a fantastic play. Think about it. And how relevant it is to this day and age where we've actually got to start to think about which patients do we give the drug to. So here's my next question. You've got 3 patients in front of you, and in your pharmacy, all you have left is one 12-week course of Vicirax Ex Vera, and you have one 24-week course of Cimeprevir with Peg-Riba. And in front of you, and I apologise if these names are, but you've got Stavros, a 31-year-old street homeless heroin addict. You've got Kostas, a 58-year-old haemophiliac lawyer with a FibroScan score of 6.2. And you've got Stefanos, a 62-year-old with 5 out of 6 fibrosis on his liver biopsy. So my question to you is, who gets the all-oral therapy? Hands up if you'd give it to Stavros. Anybody give it to Kostas? And who would save it for Stefanos? Okay, interesting. I won't tell you how I would vote on that. Right, I just very quickly, and I know we're running short of time, want to let us reevaluate why exactly we're treating hepatitis C in the first place. Now, we all know that treating hepatitis C prevents cirrhosis, decompensation, and premature death. This is what my hospital wards are full up with. You invented democracy. Of course, we invented NICE. And NICE has deemed that it's very cost-effective to treat these patients, because what you can see in those blue bars is that we are anticipating in the UK an increase in decompensated liver disease in the UK, which is incredibly expensive to look after. It fills up our hospitals, so however expensive the drugs are, it makes sense. And we know then that by treating it, we reduce mortality. But did you realise exactly how much you reduce all-cause mortality? Not just liver disease, stroke, cardiovascular disease, deaths from non-liver-related cancers by treating hepatitis C. So we shouldn't just be treating because of advanced disease. We forget that we improve quality of life and stigma. This was a French study that shows that more than half patients living with hepatitis C experience depression and poor cognition, fatigue. My critics say, yeah, but they're a bunch of layabouts. They're all drug addicts. They lie around on the sofa all day. Of course they're depressed. But if we treat their hepatitis C, they get better. They get more productive. We need to grow the economy. To grow the economy, we need a healthy workforce. We need to get these people treated so they become more productive. We also need to lower the prevalence rate. Remember that those people who are at risk of infecting others, as George said in the last presentation, are the biggest challenge that we have. This is Scottish data. Scotland has attacked hepatitis C. The blue bar is that increasing rise in decompensated cirrhosis that's going to cost us a fortune. What you can see is that if they only treat 250 injecting drug users a year, that blue line carries on going up. By treating 2,000 drug users a year, that line is flattening out. Scotland, I think, has a pretty similar population or a smaller population probably than Greece, about half the population. 12 million in Greece? Something like that. It's about 6 million in Scotland. So you'd have to treat about 4,000 injecting drug users to actually turn that corner. And that's a challenge. In Scotland, they have targets, and if they don't treat that number, they get fined. So they go out there looking for them. And finally, we live in a global world. We can eradicate hepatitis C, but it's not going to work if only some of us do it and others don't. So we've all got to pull together and try and treat those people that are passing it on to others if we're going to treat it. So this brings me really to how I think we can individualise treatment. The way we've got to individualise treatment is by changing the way we work. The drugs may be fantastic, but the fact that the vast majority of people living with HCV cannot access those drugs means that has an SVR rate of 0%. We need to actually start thinking about how we're going to deliver the care to those people who actually need it. For too long, we've hidden in our universities because we've hidden behind the complexity. We've got to work out the viral kinetics. These are patients with decompensated liver disease. It's actually very, very simple now. We're about to start a study in community pharmacies where the pharmacist will do a dry blood spot testing, will diagnose the hep C, will hand out the drug on a daily basis with the methadone. The patient will never go near a doctor or a nurse. And that is a way of getting the treatment out to those patients. Prisons. In Australia, they are blitzing prisons. They're taking one prison at a time. They're testing everybody. They're treating everybody. And they're bringing down the prevalence very, very quickly. We know that people in prisons will inject drugs. But if you make sure that within a few days, everybody is aviremic, then it doesn't matter if they carry on injecting because they're not going to be spreading the disease around. So we need to think outside the box. So my conclusions, ladies and gentlemen, thank you for listening to me. The concept of individualising treatment for our patients living with HCV will become less relevant as highly effective combination therapies become available in the very near future, in the next 2 or 3 days. Our priority, I believe, as physicians, must lie in ensuring that these drugs are used wisely in order that we can bring the maximum benefit to the maximum number of patients. That is our role. And on that point, I would like to say the only other Greek word I know, Epharisto.
Dr. Brown, thank you very much for your excellent talk. We enjoyed it very much. It was very intriguing, and especially the example with the doctor dilemma, it was very interesting for us. Any questions? Professor Hadjiannis.
Well, I would like to congratulate you because your points are very important, and the question of the dilemmas, the doctor's dilemmas, have to be transferred to the society.
Absolutely.
And so that's the very important point you are making, and we have to co-work and just ourselves physicians go ahead and give the appropriate evidence to the leaders in the society, to politicians, to properly handle these dilemmas. Thank you very much.
You're welcome. Thank you.
Άλλη ερώτηση. I think we are a little bit late. Thank you very much.
You're welcome.
Enjoy your staying here.